Good afternoon, everybody. Today I'll be speaking on analysis of biomarkers, homocysteine and C-reactive protein as a risk factor for age-related macular degeneration. It's a case control study. Age-related macular degeneration is the most common cause of blindness in people over the age of 50. Approximately 8.7% of the world population suffers from AMD. The projected number of the people with this disease is approximately 196 millions in 2020, increasing to 288 millions in 2040, presenting a growing public health problem among the aged population. AMD can be classified as at an early stage or late stage. In early, we have the atrophy or hypertrophy of the RPE underlying the central macula and drusen deposition. Early stage of AMD may progress either to dry or wet AMD, and these advanced stages are associated with vision impairment. Atrophic AMD or dry AMD is the atrophy of the central macula with gradual destruction of the RPE and photoreceptors. Exudative AMD or the wet, we have choroidal neovascular membranes develop under the macula which leaks fluid and blood, ultimately causing a central fibrous subretinal scar with destruction of the photoreceptors and RPE. The pathogenesis being the nutrients and oxygen diffused from the underlying choriocapillaries through the burst membrane to the RPE and retina, and the waste products go the opposite way. The burst membrane undergoes many morphological changes with increasing age, including thickness, calcification, degeneration of collagen and elastin fibers, and splitting. Transport between the RPE and choroid can also be impaired by incomplete clearance of the waste with age, leading to accumulation of lipid-rich metabolite products. Now, the 5 concepts relevant to the cell biology of the AMD and the study is AMD involves aging changes plus additional pathological changes. That is, AMD is not just an aging change. Oxidative stress causes RPE and possibly choriocapillaries injury. Results in chronic inflammatory response within the burst membrane and the choroid, which results in formation of an abnormal extracellular matrix, which causes an altered diffusion of nutrients to the retina and RPE, possibly precipitating further RPE and retinal damage. Atrophy of the retina, RPE and choriocapillaries, and or the choroidal neovascular growths. The reason we choose homocysteine, it may include vascular damage by a variety of mechanisms including platelet activation, oxidative stress, hypercoagulability, endothelial dysfunction, and vascular smooth muscle proliferation. C-reactive protein was chosen because cellular remnants and debris from degenerated retinal pigment epithelial cells sequestrated between the RPE and the basal lamina and burst membrane may constitute a chronic inflammatory stimulus. Low-grade chronic inflammation is now also recognized to play a pivotal role in the pathogenesis of numerous degenerative diseases, including atherosclerosis and Alzheimer's. The objective of our study is to find a correlation between CRP and homocysteine levels with AMD. The importance of the study, since there is no cure for AMD, control of modifiable risk factors, which could be homocysteine and CRP, could reduce the risk of developing AMD. The materials, it was a case control study, prospective. The study participants who attended our tertiary care center aged 50 to 90 years with AMD were matched with controls adjusted for age, sex, and environmental factors. Both affected and unaffected individuals underwent testing for CRP and homocysteine, and a detailed systemic examination was held by a medical physician to rule out any systemic illness. Inclusion criteria: 50 to 90 years of individuals and patients with AMD or early signs of AMD. Exclusion criteria were alcoholics, smokers, and other conditions, hypertension, and chronic illness. Results: during the study, a total of 60 patients were enrolled, 30 cases, 30 controls. Out of the 30, 15 were males, 15 females, and out of the 30 controls, again 15 males, 15 females were there. The mean age of the patients was 66.5 plus minus 8. The normal homocysteine levels is less than 15 micromoles per liter. What we found that the mean in cases of homocysteine was 28, and the CRP in normal is less than 3. We found a mean of 13, and in controls, the homocysteine we found 13.2, and C-reactive protein 2.1. This is the graphical representation. The blue graph denotes the cases, and the red the controls. And we clearly see that the cases, the homocysteine is more as compared to the control, and the same goes with the CRP. Appropriate tests of significance were applied. Independent sampling Mann-Whitney U tests. The hypothesis test summary. The alternate hypothesis suggests a difference in homocysteine and C-reactive protein among cases of AMD and controls. After applying an appropriate statistical test, the Mann-Whitney test, the difference was found to be statistically significant. In conclusion, significant statistical difference was observed in homocysteine and C-reactive protein of the cases and controls. As homocysteine and C-reactive protein are the modifiable risk factors for AMD. The limitation of the study being a small sample size. The take-home message from this study was, since there is no cure for AMD, prevention is the first approach to reduce vision loss. Detection and control of modifiable risk factor markers like CRP and homocysteine levels could reduce the risk of developing AMD and may provide a rationale for treatment modalities. Thank you.
Thank you.
Did you rule out any comorbidities which could have also caused a rise in CRP and homocysteine?
Ma'am, like diabetes, hypertension, hyperlipidemia condition, because homocysteine are normally again raised in those conditions.
So did you rule them
Yes,
out?
we did rule them. The physician, after physical checkup, then we took those studies.
You measured all these values at one point of time, right?
Yes, sir.
So, is there any scope that you measure, consecutively, and then have a rising trend, and then you correlate that, as this increases, this also increases?
So that would have been better, because in patients with increased homocysteine, we normally give homocheck, and if there is any inflammatory condition which we did not treat at that moment, could have better.
That will be a
prognosis.
if you demonstrate rising trend with increase in the disease and things like that. That's also.
Yeah, that should have been.
That's also a good idea.
Yes, sir.
Not in your case, but
Yes, sir.
and reinforce the strength of the.
Exactly.
Thank you.
Yeah, thank you.
So I now invite